This is Average Joe PT, and what we're going to talk about this afternoon in our kind of like this is our kind of our why does therapists do what they do? So that's really what this is, and we're going to do this as, under herniated disc. So if you haven't seen my last episode, basically recorded, and it was about cervical spine and disc issues in the cervical spine, and like the three worries that you have to, three worries that you have in regards to the herniated disc, which we talked about, which was the radiating symptoms past the elbow. That's radicular symptoms. Numbness and burning, those are paresthesias. And then the grip weakness or the dropping of items and stuff like that. So I want you guys to, after this, hopefully go back and look at that one. You should see this in my last episode. So let me go ahead and just check here for a second. All right, so let's go ahead and kind of start out with this first article. So this article, this is all about the cervical disc, and what we're worrying about is about the interventions, the treatments. You know, did the therapist or the idea of the treatments, did they make sense with your actual problem? You know, when they talk about, oh yeah, we're gonna do exercise, we're gonna do joint mobilizations, we're gonna do maybe some cervical some traction to try and pull that disc apart and try and reduce the stress on the nerves of the cervical spine. Does that stuff actually work or not? You know, it's kind of like, all right, they anecdotally, it kind of makes sense that it would work, but does this stuff, peer-reviewed journals, which is what we're looking at, does that stuff actually work or does it not? So the first one we're going to look at here, this is a case report, and this was done. This is actually back in 2000, and this is an older one. So this is a report back in 2015. So safe physiotherapy interventions in a large cervical disc herniation. So what they looked at here is physical therapy treatments in a large disc herniation. Hi, Kimmy. Hi, Ann. How are you? So what I'm talking about tonight is safe. So we're looking at really the treatments of a disc issue. In this case, it can be anywhere, but we're looking specifically in the neck. So what we're looking at here is this particular person that they looked at. This was a 34-year-old woman, was seen in physical therapy treatment for signs and symptoms of a cervical neck problem with arm symptoms, kind of like what I talked about in my last video. So that I dropped. Today is Wednesday. I dropped it. Today's Thursday. Let's get ahead of myself here. So I dropped it yesterday, Wednesday, that last video. So loss of cervical lordosis, which basically means is we're looking at the neck here. And so you typically should have a disc that looks like that. Hi, Kimmy. All hearts and loves with Kimmy. So what we're looking at here is actually that they're talking about the curve. They're saying when you start to have issues with a disc, it starts to flatten out. And when you look on x-rays and stuff, that's one of the symptoms of a neck problem is their neck will be straight instead of it being this little curve, which is called the lordotic curve. And so that's what they looked at here. And so they looked at MRIs. In this case, they looked at C5, C6. If you're going to have a problem in your neck, it's going to be somewhere between C6 and C7. All right. And the reason why you're going to have that is that's where the most amount of bending forwards and bending backwards in your neck takes place. So hence, that would cause you a lot of problems in your neck. So that makes perfect sense, right? I see ya. And so In that case, that's the reason why they specifically looked at that level. And what they did is they did several things. Excuse me. They did medications, which in this case they did tramadol, and they did diazepam. So they did that. They did that as a muscle relaxer, and they did that for 2 months, as well as. So that's what they were trying to do, trying to get them this through medication, trying to get it to relax a little bit. And then basically in this one, physical therapy, she was treated there with mobilizations of the upper part of the spine from C7 to T6. Cervical extension exercises were performed while prior to voluntary extensions of the mid back. So let's talk about that for a second. What's that all mean? So here, right where the purple meets the blue, that's what they worked on there. And so they worked on where the purple meets the blue and then down a little bit. And what they did is they talked about mobilizations. All they did is have them just do, and I'm going to show you kind of in a blow up here. They just had them pushing forwards on the area. So what they were doing here is on the side here, this joint here, when I pull the two parts of them apart, what they were doing is they were just shifting forwards and backwards. They were just shifting forwards and backwards, trying to get those areas where the purple meets the blue and the blue down a little bit, getting those joints to move a little bit. And at the same time, they were doing these head where you lift up, these extensions. So that's a whole other part of the program where they think about, all right, let's go ahead and try and push this disc back into place. And the reality is, as I talked about that in my last video, is that you're not, when you have a disc problem and it's pushing out like that, and it falls back in, that area is now unstable for probably several weeks. I can't give you an exact line because it depends on what type of disc issue we're talking about. Because you have a bulge, you can have a rupture, you can have a herniation. So they go in this order: bulge, herniation, and rupture. And so depending on how bad it is, depends on if this thing's just going to move in and out all the time. So if we're talking about something that's like a rupture, that means it's pushed out and a lot of the disc is starting to leak into that space. Doesn't matter how much extension you do, more times than not, it's probably going to make the symptoms worse because the area is so inflamed, and you have what we call generally called a leaky disc, and that means that disc material inside there literally is leaking out. And what has to happen is actually scar tissue has to lay on in there, and it does that within that inflammatory period, and then gets denser as time goes on, so that it can take the stress. But the caveat with that is, because it's scar tissue, it's going to be the tensile strength of about 80%. So you lose about 20% of the strength of any area. If you're dealing, whatever it may be, whether it's you burnt your skin and there's scar tissue there, or you tore up your joint somewhere and you had scar tissue there. Scar tissue is not, cellular wise, it's not as strong as your original tissue was. And it's, like I said, it's 20% weaker. And so it is prone to injury. Hence, that's why we need to strengthen around the joints afterwards, whether it's shoulder or whether it's, in this case, we're talking about your neck afterwards, so that you don't all of a sudden hurt yourself again. That's the most important part that everybody seems to miss out on, is that piece. Is you hurt yourself, the symptoms go away, your pain goes away, and you just go back to your business, not realizing that, you have set yourself up for another issue because that scar tissue is not as strong as the old stuff was. So let's go on and talk about this a little bit more. I'm going to get my eyeballs on here because some of this wording is quite small. So they investigated. The findings from the x-rays were unremarkable, so they did MRIs on this one like I talked about. and it was a loss loss of the lordosis, or straightening of the neck, and they showed an 8 millimeter hernia in the C5 C6 area. So let's just pretend since this is a nice larger kind of blown out view of your spine, and this is just one disc and one vertebrae above and one vertebrae below in between that to give you the whole shock absorber concept to it. But what they're saying is 8 millimeters. So that's kind of small, right? That is actually huge when we're talking about the small bones in your neck. If we're talking about your lower part of your back, yeah, it's a lot more space in your lower part of your spine, and so you don't have the issues like you would when we're talking about your neck. So in this case, we are talking about the neck. So 8 millimeters is quite large. So in this case, it indented the cord and obstructed the left paracentral recesses in the foramen. So what's that mean? That means when that disc pushed back and it's far in there, it's pushing on the spinal cord area. And so it literally is leaving, that disc is pushing against the structure of the spinal cord and causing an indentation of it. So there is a physical pushing of that disc into that spinal cord area. And that's going to cause a lot of inflammation. When you're talking about the spinal cord, that's a little bit different than the spinal nerves that come off of that. Those are called peripheral nerves. But when we're talking about the spinal cord, at that point, it's not affecting just your arms. If it's hitting the cord, it's affecting from that point down. And so that's serious. So they could be having bowel and bladder issues. They could be having, their legs could be weak just because it's at the spinal cord level versus the peripheral nerves. And so in this case, they did 2 months of physical therapy to see if mobilizations, the muscle relaxers, the anti-inflammatories make a difference at all. And so let's see what they found out. So on this page, they actually show the MRI, and they show where it was indentation of the spinal cord on that area. So apparently this person had stiffness of their thoracic spine, and that's the reason why they were doing mobilizations to the cervical spine. So let's just think about that for a second. Okay. If we're dealing with neck pain and a disc issue and you have stiffness in your upper back, why do you think you might have stiffness in your upper back? The logical answer is this. Your spine is trying to stabilize itself above and below the trauma center by causing those muscles to tighten up so that you already had an issue because the spine moved too much. Okay, I talk about this as a car crash. There are many barriers that happen or failure in a car crash. Obviously, the person not paying attention, not hitting the brakes soon enough. Yeah, I'm getting your messages. Looks like one of them got retracted, Mom. Don't know why. But so when you have the treatment for this did not make sense logically, and we're talking about research here. They did mobilizations on that upper part of the spine, right? Causing this thing to move more. The trauma happened because the disc got torn, causing a herniation because the muscles around the neck area, okay, the ligaments that hold the bones together and the muscles and tendons around the area that try and keep this spine stable all failed, causing the disc to take the trauma and then the herniation occurring. So logically, you would think, why would you want to mobilize or make your upper part of your back move more now? Because right now the body is automatically what we call the CNS, or the central nervous system, to automatically contract these muscles and to try and stabilize above and below the joint so that it can try and heal itself. So you have this bird and this research mobilizing the upper part of the back, thinking, oh yeah, we need to get that upper part of the back to move. Well, that's not what you want to do, because now you're going to try and make even the lower part of the spine unstable, excuse me, by getting it to move more through these mobilizations. So it's not really a smart outcome, I would think, to try and get your upper part of your spine to move while your autonomic system, your central nervous system, is trying to stabilize this part while it heals. It's not really a brilliant idea. So right there, I see right off the bat, if I was doing this, I would not do this to someone, because it does not. If you know anything about physiology, the trauma that happened, the last thing you want to do is cause more instability within the spine. What's going to happen? This patient's going to go home. They're going to be hurting more because you mobilized their upper back. They're probably going to tell them to ice it, maybe do some electrical stim. They're going to come back the next time. They're going to be the same, because whatever you did that 15 or 20 minutes, the next 3 days or whatever you're going to see them again, the central nervous system, your body's nervous system, went and told those muscles to tighten back up again. So, I mean, it really didn't do anything besides cause the person more pain. Not very logical here. All right. So what they did do here, they did tell them to stop slouching, which I tell everybody all the time in all my videos. Don't be a letter C. So, don't be a letter C. The letter C. Don't want to be that. You want to be upright and have good posture, especially after a trauma. You want to reduce the stress on these joints as much as possible so that you're reducing the inflammation, any secondary inflammation that you're giving it. So they did that, which is a smart thing to do, so that helped. They didn't tell them to ice it. They were doing some muscle relaxers. They did. I don't see in here where they did do any icing at all. So all they said here is they did gentle oscillations to the spine. So they weren't very specific in exactly the mobilizations they did to this herniated disc, because there's several grades. There's a grade 1, okay, where you're just moving the skin. You're not even moving the joint at grade 1. So just think of it like pushing on your skin. That's like a grade 1. A grade 2, you're kind of pushing into the joint a little bit. Okay, let me see if I can get a better view here for you so you can see it sliding forwards. Okay, a grade 3, you're moving within the joint space. Grade 4, you're at the end motion of the joint space. And then the grade 5 mobilization is what you see chiropractors or what physical therapists can do now, where we take the joint at the end range and then we give it a quick thrust. So that's where you get the hair popping and cracking. And you only would do that is if you're having a lot of, let's say this person didn't have a disc issue, they didn't have any radicular symptoms or numbness or burning, and all they were is just having a lot of joint stiffness, maybe because they just had some poor posture and the muscles tightened up or whatever. It makes sense to then do a grade 5 spinal mobilization to those hypomobile segments, which is they're not normal. So you would look at all the other segments, you would move all them and see if they're moving like they're supposed to. And if they are, and there's just a couple segments that aren't, that are supposed to, then it makes sense to do that. They overutilize that treatment technique too much. But anyways, back to this article, they really didn't tell you specifically, which isn't impressive to me. So in practice, I would not use this. I mean, if I was to read 3 or 4 of these, and I would rate this as a poor research article to try and take a couple caveats to like, okay, you know, did my treatments or my techniques, could I, take some of these and expect the same kind of outcomes that they did in this research article? And I would say no, absolutely not. They did do 8 weeks. And here it says here, after 8 weeks, they're defining this as spontaneous regression of the cervical disc protrusions are reported. However, spontaneous regression of the herniated cervical disc are speculated to be rare. So what they're saying there is basically without any treatment at all, a bulge will recover on its own, and they're absolutely right. Herniation, there's nothing you could really tell because you'd have to take, and like I said, a herniation, you can still go in and out. It isn't until you get a rupture or, God forbid, the last one, which is fragmentation, which is a part of the disc breaks off and actually starts floating within the space. And that is terrible because now it's hitting, that disc tissue is hitting all over the place, causing scar tissue and inflammation to occur all the time. And that's an absolute disaster. And they might not see it on an MRI because it's so tiny. They wouldn't see it till they got in there like, oh my Lord, look at these little fragments all over the place. They talk about the nucleus pulposus. Okay, they're describing the disc itself, and I actually had that on my last video. Summarize the factors of that reabsorption of a herniated disc really can occur, and I think it does a lot. We call it phagocytosis in the medical world, where you have these little, we'll call them little Pac-Mans or Pac-Womans. It's called phagocytes, and they go in there and they gobble up all the things that they think should not be in that area, and they'll go ahead and break up. And this takes weeks and weeks and weeks. This doesn't happen overnight. They'll go ahead and chew up that disc, that's fragmentation that's in that spot, and then it'll be gone. So that can absolutely happen. They did talk about in here fragmentation. Does not, that doesn't happen with fragmentation, and that's exactly what I say. Physical therapy interventions are not defined in any of these studies. However, therefore, it is possible that a disc regression in these studies may be due to similar physical therapy interventions as described here. So they really couldn't state, excuse me, I apologize. They really couldn't state that the neck extension and the spinal mobilizations helped at all, and it was 8 weeks. I mean, 8 weeks is a long time. Anybody who's getting physical therapy, they should notice a difference within 2 or 3 weeks when we're talking about this. If your symptoms, like I say in my videos, if your symptoms aren't going out of your hand, that numbness, tingling, those what we call paresthesias, aren't going out of your hand, regressing out of your hand, going back to the neck, within 2 or 3 weeks of services, if you're getting actual physical therapy services, or if you're doing any of the treatments that I kind of show you at home, then yeah, you need to go, you either A, need to go see your doctor, or B, if you're seeing a physical therapist, say, hey, I need to go back to the doctor. It's 3 weeks and I haven't seen any improvement yet. You should see that. If you've gotten to the point where you have numbness and tingling and you got grip weakness and your hand feels heavy or your whole arm feels heavy and you got 2 or 3 weeks of physical therapy and that's not improvement, that's a clear sign that you need to go back. If you ever saw me for physical therapy and we're not seeing any improvements in 2 or 3 weeks of those, I'm sending you back because you have fragmentation probably in there or a leaky disc, and that needs to probably be surgically, if you haven't had an MRI or an MRI would die, then that needs to be done. So there needs to be other processes to that. So I'm going to give this article we're going to start rating these articles a little bit. Joe's going to give this article if I was going to give it a average Joe 5-star rating, 5 being the best, I'm going to give this a 1. This was a dud. So I wouldn't use this on anybody. So this is a dud. So this was safe physical therapy interventions for a large cervical disc. Dud. All right. Next one. This research article is a lot more robust. This was outcomes of active cervical thorax or exercise on dynamic intervertebral foramen changes in the neck, patients with disc herniation. So what this is they're talking about right where my finger's at. Okay, that spot right there, all the way through every segment, is called the intervertebral foramen. Foramen means hole anywhere in your body. Okay, my eye sockets, that's a foramen if you want to know. Everybody's eye sockets, right? So intervertebral, which means in between the vertebrae. Okay, so that's what we're talking about here, folks. And this was a good study. This was actually done by BMC. This is a research musculoskeletal disorders, and this was done back in 2022. So this is last year. This just came out last year. This is what I'd be looking at, 2 or 3 of these to say, okay, I'm on the mark with what I'm doing with my patients, or hey, they need to go back and do something else. So this is what physical therapists should be doing. And I'm giving you guys the caveats of what should be done. So hopefully, if you got problems, you're hearing it from what they call the horse's mouth. So let's look at this one. So this background here. This is to better understand the mechanics of factors that affect the intervertebral alignment throughout active exercise. It is necessary to determine the spinal movement, and they say kinematics here, but it's the spinal movement. This is a fancy word for that, when subjects perform spinal exercises. This study aims to investigate the outcomes of active neck exercise on the intervertebral foramen. So they're looking at someone who's got a disc herniation. They're doing exercises with a disc herniation in the neck, and they're basically saying, were there any changes in the neck in this whole area with the exercise? So what they look at, 30 people diagnosed with a C4, C5, and so either or, C5, C6 disc herniation, receiving 2 months, 8 weeks of cervical exercises, followed by video fluoroscopy images. And so what the video fluoroscopy is it's, and they do this for patients who have spinal injections for pain. You run the fluoroscopy. It's essentially a live x-ray. It's 2 screens that the physician's looking at, where they can actually see, like, let's say we're doing an injection on you, they would put a needle in on this and be able to see it live happen. So they're looking at a back view and a side view. They're looking at 2 different views, either a top-down view and a side view, or maybe a front view and a side view. So you're always looking at 2 separate areas at the same time. It just gives you a better overall idea of where you are in space when we're talking about someone's spine. So that's what they looked at. They looked at C4, so we're going to count down from the base of the skull, 1, 2, 3, and 4. So right where my finger's at here is what they did there, and the one down below it. So if you're talking about, that's where you're talking about. So I'm going to give you a side view here. Sorry about my mic, but it's right up there. It feels like it's at the base of your skull when you touch C4, C5, and C5, that area. So results showed, let's look at the results here. The active cervical exercises, so they're looking forwards. They're looking at pulling your neck back, which is retractions, and lateral flexion, side bending, away from the affected side of patients with this problem, with a disc herniation. So let's say it was on the left side, they would be tilting this way. They would be tilting back, and they'd be tilting forwards. And they would be doing the pullbacks. So they looked at that, and they basically said here that there was a significant reduction in C2 and C3 and C4, C5 areas of this foramen when they did those exercises. So 8 weeks of exercise, including repeated those exercises, which were retractions, extensions, and then lateral flexion or lateral bend. Movements in a lesion, they call a cervical herniation a lesion, to significant changes and improvements in vertebral foramen area of the patients with a disc herniation. So they were saying that they saw improvements in that space with a disc herniation, because with a disc herniation, it takes up that space. Okay? So that's what they found out. Now, I want you to stay with me, follow with me, because that's exactly what they said. Now, I haven't read this yet, but I'm going to give you my idea of what I just thought of and probably what happened. Okay? So let's read this a little bit further, and I'm going to tell you that a conclusion from a professional, and then me reading it as another professional, kind of looking at it deeper and saying, hey, did you guys take this in consideration when you saw the results? Did you guys consider that in the results? So this is the difference between a lay person reading this and saying, oh, if I do these things, I'm going to get better, versus someone who does this for a living, who went to school a long time and reads this and says, wait just one moment. You guys missed a few pieces. So let's go ahead and read on here for a second. Now, overall, this is a solid research journal. This is a peer-reviewed journal. And what I mean by that is you had other scholars that looked at your evidence and said, okay, it's good. You need to rewrite this section. You need to rewrite that section before we're going to publicize it. And then they come back and they got to do a third rewrite. You know what? We don't like this piece now. You're going to have to rewrite this. And what about this kind of data? Why was that person excluded from the study or something like that? So that's peer review journals. It is rigorous to get into these journals. This isn't just somebody like me that just writes something and then just can send it into a journal. It doesn't work that way, because we're using the scientific method, and it's like, okay, we want to hold that this is true every time it's done, so that if I look at 4 or 5 journals that all did the same thing, okay, of 3, let's say 5 different research articles, peer-reviewed journals that did the exact same treatment and they had the exact same outcome, I should expect that with my patients, when I do the exact same thing, that's going to be, okay, it took 4 weeks, or it took 6 weeks, or it took 10 weeks. Okay, that's where we come up with this as physical therapists. Like, we don't pull this, or you shouldn't be as a therapist or a medical professional. It's a doctor, medical doctor, whoever it may be. Let's say they're prescribing a medication. We're prescribing certain techniques, and whether it's treatments at the facility or certain exercises or certain things that we're doing, we're basing that on research, saying, okay, it took this long to recover. We suspect you should be right around that same time frame. So like I said, they did the retractions, they did the extensions, and they did the lateral flexions. That's what those 3 movements are. They also used what's called the McKenzie treatment. So what that is, just a brief, there was a gentleman, his name was Robin McKenzie. Yes, I know it sounds like a woman, but it was a man. He came up with a philosophy a long time ago, and he basically showed that if you have a person do certain movements in certain positions for periods of time, you can get the disc to recede. And so that's where this comes from, and that's where those exercises that this person did and this research article on the neck did. And so they did it for 8 weeks. And so if I was to do this, and I found 3 other research articles that did the similar things and took 6 to 8 weeks, I expect that doing those 3 types of techniques, okay, should give you the similar result with the same type of patients that were used in this study. So I would say, yeah, if a patient is like, how long is it going to take for me to get better? Well, with 6 to 8 weeks. And I think I pulled it out of my hat, and I didn't. It was 5 recently peer-reviewed journals that did these things, as well as my 25 years of experience doing various techniques through the years, comes up with that type of answer. So they did all those movements, and like I said here, and they did this with a SPSS statistical analysis. Now, I say that because it's called the Scientific Package for Social Sciences. I had to learn that program when I went through my doctorate back in the early 2000s. I had to learn that. I mean, forget physical therapy. I thought that was hard enough. I had to learn how to do statistics after several classes, but then had to learn this program on my own with one other person. And let me tell you, I thought I was going to lose my mind. Let me break this down here. So the results were, there was 30 patients, 14 were female, and 16 were males. And the date range, or the age range, was 20 to 50. So in the mean, not average, the mean, which is a lot more data sensitive, was 30.5. So that's pretty good. So that's, that's a solid in between. And I say that why did they pick 20 years to 50 years old? Why didn't they not pick 60 years old? Why did they not pick an 18-year-old or a 19-year-old? There's a couple reasons for that. Let me just get a sip here. Reason number one, before you're 20, you have a lot of blood flow still going around where my finger's at. The outer part of the disc has still vascularization when we're young, because obviously we're growing fast. As we age, get in our 20s, that vascularization goes away, and then it's only nourished by synovial fluid. So that's one reason why. Why didn't they pick 60 or 70? Because at a certain part, this disc actually starts to ossify. It actually starts to get hard. And so your likelihood of getting a herniation or a disc rupture drops as we age. Now, you can get spinal stenosis, and I'll probably going to do a couple videos on spinal stenosis, another one on facet syndrome. I'll probably do one on intervertebral foramen issues, vertebral fracture. There's all kinds of stuff I can just do on just this thing right here. But that's the reason why they picked that age group. It's like, why didn't they just kind of pull the rabbit out of the hat? No, there's a reason why they did that, and that's the reason why. All right, so, and that's the reason why they picked why did they measure that hole? Because the disc herniation fills in that hole, hence the hole smaller. So if the hole gets bigger, that means the herniation's not there anymore. So that's just logical deduction. And really, they really used the McKenzie model completely when it came to this. They didn't do any spinal mobilizations like we saw in the last one. They didn't do any medications, muscle relaxers. So they really looked at, if you did these exercises and you had a disc herniation and you were in your 30s to 50-year-old range, let's say you were in your 30s, a sweet spot for where this study was done, and you gave it 8 weeks, you did these exercises, and you didn't do anything else, would you have a positive recovery for this? And it said you would have a positive recovery for the foramen having a larger hole. You see how that is? That's what the research says. Now, you can't, in the research world, you can't in good conscience then do a deduction and say, oh yeah, well that means I don't have a herniation anymore, and now I don't have any pain, I don't have any more inflammation, blah, blah, blah. That's not what that means. All that means is that the herniation is reduced because the hole in the foramen is larger. Now, does that mean that you don't have any numbness in your hand, that you don't have any grip weakness, that you have any numbness or burn in your hand? No, it doesn't say that at all. and it doesn't even imply that. That's so that's one we can take away. Like, you can do all these exercises and you would hope that your symptoms would resolve. The clear idea is actually subjective. And so when we talk about, what did the patient tell me? Has their symptoms improved? Has their numbness and burning gone away? I do grip strength testing, what we call a dynamometer is a grip tester that kind of, you can squeeze it and tells you how many pounds you're actually squeezing. You get that, oh, wow, it went up by 30 pounds. Okay, great. That means your strength is returning. Or you can literally just, that's a lot more sensitive. But if it feels like I'm not dropping anything at home anymore, my arm doesn't feel heavy like it used to, I have more neck motion and it doesn't hurt like it used to, you can just, anecdotally figure out like, yeah, okay, it must be doing better. But that research article really does tell us that, yeah, if I found 3 more articles that all say that those 3 movements reduce it, I would definitely implement that in my practice. So this is pretty solid data, but you wouldn't want to just take this one research article and run with it and start doing treatments on anybody or yourself, right? Like, oh, the doctor said I had a herniation or thought I did, or I start having arm symptoms. I wouldn't just do these 3 exercises. Okay, I would use these exercises in conjunction with the postural education we talk about, the icing, the anti-inflammatories, the TENS unit, the Theracane, all those different treatment techniques I've shown in my previous neck videos, pre-recorded videos that are probably a year and a half old at this point. You do all those in conjunction with this. That way, let's try and throw everything in the kitchen sink at it to make your symptoms resolve. But we know that these 3 movements will significantly improve your symptoms, and it doesn't hurt to have a little kick with all those other things by reducing your inflammation with the anti-inflammatories, the icing, the resting, so that you're not excessively causing more inflammation by getting that disc moving in and out so much. Allowing that scar tissue to lay down is, if you get that disc in a good spot and it's not pressing against the nerve anymore, and you can get scar tissue to lay down and hold that in place, that's what you want. You don't want scar tissue to lay down with the disc being pushed out. That's not smart. Now you're going to have a lot of problems with that. You can have scar tissue in the disc space, and that's what happens a lot with low back patients, and we'll talk about that in another video. You can happen up in your neck too, but if you don't give your body enough time to heal and listen to the professionals, your scar tissue is laying down immediately, and if it's laid down in a wrong pattern or a wrong movement, you can actually make your symptoms worse, because once that scar tissue is laid down, that's it. The doctor rarely goes in there and cuts that out. And if they do, your body's already, it's hard to fight your body at that point, because your body it's already told itself, send more scar tissue there, and it will. It'll send it right back to that same spot, and it'll make it twice as hard and thicker than it was before, because it's like, it knows it got traumatized, because that surgeon goes in there and cuts that out. Your body doesn't know whether that was a trauma from a fall and it tore that scar tissue, or the surgeon went in there and surgically removed it. The body's going to respond to it exactly the same. So that's why sometimes we'll do steroid injections, because steroids actually shrink scar tissue. Tidbit for you there. They do it a lot with cosmetic scars on your face or anywhere on your body, but internally it do the same thing. It'll shrink scar tissue, and so hopefully it'll take some of that stress off of that, because they'll look at an MRI, it's like, yeah, it looks fine. The alignment's in good, and I don't see anything. Nothing's wrong with the hardware. Well, on an MRI, you can't really see scar tissue. So a lot of times these patients go back and back and back and back for more surgery, and it's really just scar tissue. It has nothing to do with the disc itself. So, I wish they would listen to average Joe, but you can lead a horse to water, you can't make it drink. All right, so the rest of this research article goes about. Let me turn my little Scully guy here. Got him lit up for you. See his nose? Got him lit up for you guys. So this is a significant article, research journal, because it goes into serious data measuring everything, all the movements, the average, the mean, the overall percentage. I mean, this is a solid research article. So I would take this and take 2 other ones, 3 at the most, and say, okay, I'm going to run with these 3 exercises. Now, I've been trained in Robin McKenzie years ago for the lumbar and the cervical spine. So I know this stuff works. I used it in practice for a long time. But this is an updated research article that just justifies what I've been doing for years. And this is kind of just an updated one because, you don't want your research to be older than 5 years. Anything other than that, it's kind of like, okay. You want some new stuff, and then you might take an old research article and just, mirror it up to the new stuff and like, okay, it's still saying the same stuff. You might get a new gizmo, a new statistical model, maybe some new technology to measure something a little bit better. And so you always want to look at that too. But I would say if I had to run with this, and this is a good one, this is a 1 to 5 star. I'm gonna give this a 3.5 star. I'm not gonna give it quite a 4. And you're like, what the heck would you give a 4 or 5? The study I did, I think it was the first week where it had like 3,600 participants over 10 years, and it was a multi study. It looked at several different studies over 10 years, and it all showed the same thing. Yeah, that's a 4.5, 5 star. This is 3.5. I'd have to look at, we'll look at maybe 2 or 3 other research articles in the same vein of herniated disc in the cervical spine, and exercise. Maybe it would be exercise and manual techniques. It would be this exercise that they showed in this one, when maybe they would add another intervention, and then if it would say the same thing, okay, then I'm going to start giving a 4 star. So that's how we're comparing that. So I'm going to give this is a good one. This is 3.5 stars. So anyway, so that kind of really gives us a good idea of this week in the research for a herniated disc. So if you guys have any thoughts or questions, you can always DM me down below. Hopefully you'll see this afterwards, and maybe you'll DM me afterwards. But until next time. Oh, one more thing. I'll probably do a walk tomorrow, and hopefully you guys will meet me up for that. And I'm going to do a video this weekend, and it's going to be recorded. And I think I'm going to do it on, let's see, I'm going to do it on the cervical spine. Let's stay up on the cervical spine, and let's do it on the facet joint. I haven't done a real good one on the facet joint lately, so let's do it on that one. So stay tuned for that one. All right. Until next time, Scully and I always like to say, look up and keep smiling. See you next time, folks.